Lewis, I just want to tell you how wonderful you are, because you're just there and you respond really quickly. And I know I keep sending you messages about syphilis, but it's one of the most complex diseases I've ever dealt with.
It's not actually, but I think part of the problem is we've got such terrible old-fashioned tests. That's really the problem. You know, if we had better tests for detecting infectivity or whether someone's got ongoing disease, that'd be great. But, you know, the RPR really is the same test that used to be called the Wasserman reaction in 1904. It's no different. You know, that's where we're at, you know, so that's where it becomes difficult, I think, because it's not good technology.
So is there any appetite to explore that with the importance of syphilis now in Australia?
Yeah, there's all sorts of other things being done. Most of it's more related to how do you make a good diagnosis of neurosyphilis. That's where most of the work's being on. And everyone's looking at all these various proteins and various things, but none of them are commercially available, and none of them none of them are 100% accurate. I think that's the bottom line. So you're always going to have this element of maybe, maybe not. And that's really what makes the whole thing of syphilis quite difficult. And the RPR is a crappy test, really, but it's the only one we've got to know about response to treatment and reinfection. So, you know, we are labouring badly, I think, under current technology with syphilis.
Yeah, it doesn't seem satisfactory, really, because I'm more excited about acute ones than the neurosyphilis, which we don't see that much of, and somehow or other people seem to get treated before that tertiary stuff kicks in. But anyway,
Sure.
That's interesting.
Yeah, but of course you can have acute secondary neurosyphilis as well. That's the thing that gets missed, I think.
Ah, okay.
Sorry to interrupt. We've just had some more sites join on, so that discussion's not part of the questions. These two are just catching up, I think.
Yeah, we're just chatting.
Yes, but we might get started now because it's 12 o'clock, and I've seen a couple of sites join on, and we've still got some more to come. So we'll get going because I know how busy you all are. I just wanted to say welcome to our syphilis video conference. I think this is number 5 or number 6. So yeah, we've done a lot of presentations this year, which is fantastic. I'd just like to acknowledge the traditional owners of the land on which we stand, which is the Wadjuk Noongar people, and pay my respects to elders past, present and future, and also like to acknowledge the traditional owners of the land on which the people in the region are on today. I just wanted to introduce our 2 speakers for today. So we will be having a virtual panel, which I think is great, in these times that we can do that. So we've got Dr. Lewis Marshall with us today from South Terrace Clinic. We've also got Jan-Marie Grantham, clinical nurse specialist up in the Pilbara, who's giving us a wave. So thank you very much to those who have sent through questions. I think we've got about 12 that we will go through, and then at the end there'll be an opportunity to ask some additional questions if we have time. But I would like just to ask everybody to please keep your microphones on mute just so we can hear Lewis and Jan-Marie nice and clearly, and then when we get to question time you can come off mute if that works for everybody. Alright, I think we might have a bit of feedback coming through there, but we'll move on to the questions. So Lewis and Jan-Marie, I'm not sure if you want them in order, but I've just sort of tried to break them up into sort of testing and diagnosis, treatment, and then we've got a few other sort of miscellaneous questions towards the end. So I've done my best. But the first question is, what age should we cease screening asymptomatic people in high-risk communities? So I'll hand over to our lovely panel to answer that question.
Okay, so my understanding is that the recommendation currently is 15 to 29 is the screening age for asymptomatic people in high-risk communities. But I mean, obviously that's based just on a standard age thing. But of course, if anyone's got any risks, you're going to be testing them. So I don't think it needs to. It obviously wouldn't stop at 29, but that's the standard. And I did check this with my mate Donna Mack, so she told me it was 15 to 29, so that's the official age, but of course it would depend, as I say, on circumstance. So I think if anyone's is perceived to be at high risk, they should be screened. I don't think there should be any impediment to offering people syphilis serology where applicable, and in reality I think we're at the time now where that should also include HIV screening. I mean, you know, the days of half-hour pre-test counselling are well and truly gone for HIV, and if we're offering syphilis screening, we should be offering HIV screening. That's my personal opinion. I know that wasn't part of the question, but I just think it's, if we're going to be taking blood, why aren't we doing HIV testing as well as syphilis screening? So I'm happy to take comments about that, but that's what I would feel.
Yeah,
so
and certainly in the Pilbara, our cases, we've had positive cases from asymptomatic screening from 14 to in their 60s. So really, you know, we don't have a cut-off age.
No, I mean, that's the official policy document that I was quoting, but you're right. I mean, you know, if people are sexually active outside of a monogamous relationship, then by definition they're at risk of acquiring syphilis. So, you know, there should really be no impediments to screening. Should I go on, Rudy, just to the next question, or?
Yeah, so we'll move on to the next one. But Lewis, I was wondering also when you answer this one, if you could explain what an RPR is, in case anyone on the BC isn't across that. So the second question is, how do you establish stage of the disease based on RPR level in absence of any historical syphilis results?
Well, this is difficult. I mean, RPR stands for rapid plasma reagent. It's just a way of doing a test. It's a very antiquated test. It looks for how much charcoal clumping there is on a slide when the patient's serum is added to various chemicals. So you can imagine that, therefore, that's not a very accurate test, because people have to compare the amount of clumping they see to a chart. So they might think it looks like this much clumping, and someone else might think it looks like this much clumping. So you can see that's why there's variability in this test. It's not a very good test. The RPR generally, if it's high, and we're talking high, we're talking greater than 32, tends to indicate more recent infection. But I'm sure you all know the national case definition, that if there's no previous serology or there's no indication of primary or secondary syphilis based on symptoms, then patients should be treated as late-latent syphilis. So I think, you know, personally, if I had someone with an RPR of 512, I'd be knowing that that was acute syphilis and treating them accordingly. But in reality, if you haven't got previous serology and no symptoms, then it's difficult to actually make that diagnosis based just on the blood test level. So that's why often the recommendation will be to treat them as late-latent syphilis, even if they've got an RPR of 32 or 64.
Thanks, Lewis. Has anyone got any further questions or comments for Lewis or Jean-Marie? Do you have anything further to add to that?
No, Rudy.
Great. Thank you, Lewis. That was a very comprehensive answer. So the next one is, what is the significance of an RPR of 0 and a positive TPHA? Would it suggest a late infection? And I might also ask you to just explain TPHA as well, Lewis, while you're at it.
Sure. So TPHA has really been taken over now by TPPA. They're both the same test. It's called treponema pallidum. H stands for hemagglutination, and they used to use red blood cells to do the test, and now it's called treponema pallidum particle agglutination. That's what the P stands for, and they use little plastic beads to do the test. But they're the same test. Again, 1950s technology that we're using, so it's not fabulous. The EIA, or the total antibody, is also done as well as the TPHA, or TPPA. So you wouldn't get a TPPA on its own. You'd always get an ELISA, an EIA, or a total antibody, and the TPPA, and they look at the same antibodies. So they both look at IgG and IgM antibodies in the blood related to syphilis, and these are syphilis specific. So if someone's ever had syphilis, this test is positive for the rest of their life, generally. I mean, there are exceptions, but I won't bore you with those. But essentially, people, if they've ever had syphilis, their TPPA and total antibody will be positive. Now, the RPR being negative, the RPR is slower to become positive than the TPPA. So if the RPR is negative, it could be one of two things. It's that this is very, very early syphilis and the RPR therefore is not positive, or it could be that it's old treated syphilis, because the RPR will go to 0 after treatment, generally, or it could be old untreated syphilis, and we have no way of knowing based on the serology whether it's old treated or old untreated syphilis, and that's why we need treatment histories from patients. If they've got positive syphilis serology, we need to find out as much as we can whether they've been treated in the past, because we can't interpret syphilis serology without a treatment history. So an RPR of 0 and a positive TPPA and EIA, that's a fairly common presentation, but it could be one of three things. It could be very early disease, old treated, old untreated. It would be very uncommon, in fact it doesn't happen, that you wouldn't have a positive TPPA and a positive total antibody, and for that to be a false positive. That's why we do those two tests, because the screening test is the EIA, the total antibody test. That's the screening test, and if that's positive, the lab will automatically do the TPPA to prove that that's a true positive and not a false positive. I hope that makes sense. It's sometimes a bit tricky to understand, but that the TPPA and the EIA are they're identical type tests, and if one's positive, the other should be positive. If only one's positive, then that could be a false positive. Clear as mud, probably.
Are there any further questions or comments for Lewis around that question? No? All right. We will move on to the next slide. All right. Number 4, why do you need more treatment for latent infection than acute infection with syphilis?
So syphilis is a very slow reproducing organism, around 72 hours generally to reproduce. So that's why we need to use benzathine penicillin, because that produces low levels of penicillin in the blood that are consistent. If you just had oral treatment, it would do this, and you might miss the fact that you've got a bug reproducing when there's no antibiotic around. So that's why we use benzathine. Now, when it's latent infection, if that person's been infected for 3, 4, 10 years, the syphilis is even slower to reproduce. It really is a very indolent disease, and it takes a long time to reproduce. So if you only treat them for the week, they may still be reproducing at 10 days. That's the theory, and that's why we give longer treatment for latent syphilis than we do for acute syphilis, to try and mop up all those organisms when they're reproducing, because the penicillin only works when the organism is reproducing.
Thanks, Lewis. Any questions for Lewis on that one? And if you are the person who sent through that original question, please feel free to ask for clarification or more information if you need it.
So, Lewis, that's really helpful. What's the story with saying once you've treated them that 1 week is all right after that? Obviously you're never meant to have unprotected sex, but, we specifically say don't for a week when it could be dragging on a little bit. Should that be 2 weeks, or am I giving the wrong information and it's meant to be 2 weeks?
No, it's a week, because after a week they're rendered non-infectious. I mean, people with latent syphilis aren't infectious anyway, because we've got so few treponemes around, and they're not going to be out on the skin where they're going to infect anybody. So they're only infectious for a week post-treatment. So
I was meaning the acute ones there. Sorry, I was meaning the acute ones.
Well, it's just a week, yeah. After a week, the organisms are dead, yeah. So
okay,
a week
thanks.
is fine, yeah.
Great, thank you, Lewis. Question 5, and sorry, Jo-Marie, feel free to jump in as well. Number 5 is, are there any new treatments on the horizon?
Not that I'm aware of. I mean, the one good thing about syphilis is that nowhere in the world is there resistance to penicillin. There are very few other organisms where that's true. They've tried azithromycin, and that looked very promising at one stage, and so people were treating people with oral azithromycin, but resistance has developed to azithromycin, and certainly we have azithromycin-resistant syphilis here in Australia. And certainly in Europe, that's been well recognised. So we can't use azithromycin now regularly or routinely to treat syphilis. But as I say, there is no resistance to penicillin, so it is by definition the drug of choice. And as I'm sure you know, in pregnancy, it's the only drug that can be used. You can't use doxycycline, oral doxycycline, and we always get nervous about doxycycline anyway, because someone has to be really quite adherent to their doxycycline for it to work effectively. As I said before, it's a slow-growing organism, so if you don't take the doxycycline twice a day, every day, you can imagine that there will be times when syphilis might sneak through the cracks. So penicillin is the drug of choice.
Thanks, Lewis. Anyone got any other further questions about that, or any clarification required? No. Is everyone taking lots of notes? Number 6 is widespread use of benzathine penicillin affecting anything else that you're aware of?
Well, not that I'm aware of. I mean, I think probably this question might be better sent to a ID or clinical microbiologist. But I mean, lots of things are now resistant to penicillin. Of course, like staph, we can never use penicillin, and gonorrhea, we can't use penicillin mostly. Although that's not true up in the north. Still, we still have gonorrhea that's sensitive to penicillin up there, but. I'm not aware of anything particularly. As you know, it's also the recommended treatment for prevention of rheumatic fever problems. So it's fairly widespread use throughout rural and remote WA. There are some streps that are still very sensitive to penicillin, and they don't seem to develop resistance, but I'm not aware of a particular thing there. Benzathine has been identified as the major cause of ongoing resistance for other organisms.
Perfect. Any other questions about that one? Feel free to jump in. So question 7, what are your thoughts on giving 2 injections of LA bicillin a week apart for pregnant women to make sure that the treatment is sufficient?
Well, there's no data to suggest this is required. There's been various studies, and the outcome is basically the same. So, if you've done, that's of course assuming that this is acute syphilis, of course. So, acute syphilis, you would give the 1 injection. As the recommendation is to treat syphilis in pregnancy the same as you would treat syphilis in a non-pregnant person. So 1 dose and 3 doses. I think those of us old enough to have remembered Randy Spargo in the Kimberley, that was standard to give 2 doses to everyone in pregnancy, but there is no data to support that. It's not going to do any harm, although 2 big injections is not very pleasant. But there are no data to say that in a person with acute syphilis. So, as I say, if they've got latent syphilis, they need 3 doses, just like anyone else. If it's acute syphilis, then 1 dose should be adequate. That's the accepted recommendation.
Okay. Thank you. So the last question on this slide is, if we say that a week after treatment they can have unprotected sex, why do we also do the 3-month test to establish successful treatment?
So the two different things here. One is about saying whether someone's infectious or not, and after a week after treatment they're no longer infectious. So that's what that's about. But the RPR, which is the test that we do to monitor response to treatment, is slow to reduce. And a minimum would be 3 months. In fact, the recommendation is that it should have twofold decrease over 12 months. That's how slowly it can reduce. So, again, we're dealing with old technology that doesn't really reflect infectivity or response to treatment. We don't have a test that tells us accurately whether we've got live organisms or not. We don't have such a test. But based on a lot of information, we know that people are no longer infectious a week after treatment. But the response to treatment, which is measured by the RPR, takes at least 3, if not 6, if not 12 months before we can say that they've had an adequate response to treatment. So that's why there's the two different parts of that process.
Yeah, it's very interesting. Thank you. So this is a question that we sort of needed a bit more clarification on, if anyone is on the line and wishes to provide that. There's sort of two parts to this question. So the first part was, how was sexual health treatment provided during the COVID-19 pandemic with the borders so tightly closed? Is the first question. And, anyone from the region, please feel free to jump in on that one. So no one had any issues.
I'm not quite sure what the
question is asking.
No, neither do I. That's why I was asking for some clarity before I answered it, because I wasn't quite sure what I needed to answer. And then the second one the same. So I'm very happy to talk about what's happened to us in the COVID-19, but I'm sure you know about it just as much as I do. I'm sure you've all seen the data where we had reduced screening during the pandemic, which I understand was a greater reduction in the metropolitan area than it was in the regions. So well done you regional people for keeping going with the screening. You did better than we did. And certainly here at our clinic, we sort of saw, we did quite a few telephone consultations with people with chronic conditions, but of course people with acute symptoms still had to be seen, and so we made arrangements to see them with appropriate PPE, etc., if required. But I wasn't quite sure what the point of that question was really. So has anyone got any clarity on those questions that I want answered, or otherwise shall we just move on to the next one?
I think we might move on if the person who asked the question maybe isn't on the line. So question 10, a really important component of the response. So how are we doing with congenital syphilis?
Well, my understanding is I think we've had 4 cases since 2018, 2 in the Pilbara and 2 in the metropolitan area. One very recently with a second trimester loss, basically. So we still haven't had lots of cases, but I mean the real problem, of course, is getting people to have early antenatal care, and really what's also really important is to continue to test during pregnancy, and I'm sure you all know those recommendations better than I do probably, but we're looking at least 3 tests during pregnancy, 1 at delivery and then 1 at postnatal as well. But whenever I talk to my O&G colleagues, it's like apparently the assumption is that once you're pregnant you don't have sex again till you deliver. I mean, really? So I think particular partner change in particular is a very important point to try and ascertain and to retest during pregnancy, because if we miss a case of congenital syphilis, it's a disaster. That baby's born with significant handicap, and it's really important that we find patients, and particularly if we're finding them during pregnancy, it means that they're recently acquired, and early treatment will be curative. So again, how important it is that we continue to screen both at booking, whenever that might be, but also during pregnancy as well.
Thanks, Lewis. Jan-Marie, do you have any further comments from a regional and remote perspective?
Well, obviously we had the good fortune to have the 2 congenital in the Pilbara. So we've, certainly from our region, we've really tried to connect antenatally with women, including working with the midwives, child health nurses, trying to give as much education as we can to all the doctors in the region. Projects like the Baby Basket projects, so we give incentives for regular testing. Any screen that we do through our services at Pop Health across the region, if they're childbearing age, we offer a pregnancy test. So yeah, we're acutely aware of the need to really get on top of these women and prevent any more congenital births.
Thank you. So a couple more of formal questions. So the question 11 is, how can we engage doctors to raise awareness of syphilis and highlight the importance of testing? This is actually my question. It's something that we talk about within the regional sexual health teams quite a lot, and I know there probably isn't, one simple answer. So I thought it was a good opportunity with all different regions and different people on the line to sort of talk about what might work for them and, that sort of thing. So please feel free, Lewis.
Well, I think one answer is food. It's always the winner if you ever want to get people in a room. But really, it is, unfortunately, it's just one of those things where we just have to be consistent and a bit like water dripping on stone, that you just continue to raise the message and continue to raise the message. And of course, also up in the, in remote and rural, you've got the problem of locums and people coming and going all the time, which is very wearing on all of you working in this field. But I really don't have an answer. It's just that the consistency of message, I think, is really what's important. And whether, and if you probably do have this already, but pre-printed forms so that people don't have to think. They just say, all you have to do is take the blood and the form's already done, and they don't have to think about what to ask for. Sometimes that's helpful. I know that sounds a bit condescending, but, people are busy. If you want them to do something extra, you have to make it as easy as possible for them. So, but I don't have the answer, and I'd be interested to see what other people might think.
Thanks, Lewis. Veronica and the team at Aqua, did you want to talk about the screensaver? Do you have access to a microphone?
Yeah, hi, I've got Sunny and Derek here as well. Oh, well, no, we just wanted to, make people aware that our graphics team has put together a screensaver that we're happy to share around, so that it goes on to prompt, hopefully might support helping doctors to think about syphilis testing. It's just very simple message. It says don't forget syphilis testing, especially pregnant women, youth or young people, and MSM. So it's just a sort of a simple screensaver that, I think it's just one of many different things we need to think about, but it's something. So happy to share that with the group, and you may already have it because I know Rudy sent that around earlier. Yeah.
Thank you. Has anyone else got any strategies that have worked well for them?
We, again, as Lewis said, it's just about being a dripping tap, basically. We just continually educate the doctors, both the GPs and in the acute setting. We do, we also do the asymptomatic screening program. So as Lewis mentioned, we have pre-printed forms, and the aim of that is to get nurses to champion that, so that doctors don't even have to see the nurses can do it. Thanks,
Jan-Marie. There is a bit of echo going. I'm not sure if everyone else can hear this. I think Swams, if you can just pop yours on mute. There we go, it's gone. All right, thank you very much for those strategies. Hopefully they've helped. The last question that we had submitted was, why does the Kimberley Population Health Unit have a syphilis register, but there is not one available for the rest of WA?
Well, this is historical, really. I mean, you may not be aware that the syphilis register in the Kimberley was started by the nuns that also worked at the leprosarium. So this was a public health initiative, again, with Dr. Holman and Dr. Spargo to set this up, given that they had very high rates of syphilis in the Kimberley at the time, and realised that you can't treat syphilis without a register of previous negative results and previous treatment history. So that's been going for many, many years, even older than me, so that says something. But to set one up is expensive and difficult, and there are all sorts of issues about privacy that perhaps didn't apply particularly in the 70s. We do need to have negative results, and getting negative results on a register is problematic, as you can imagine. But without negative results, it's very difficult to interpret the positive results. So there is a process happening as we speak, as we all know, but hopefully we will have an effective statewide register that can help us interpret this serology. But it's really it's an historical issue, really.
Thanks, Lewis. Have anyone got any other questions or comments about a syphilis register? As Lewis mentioned, there is a lot of work being done within CDCD to establish a register, and there's a lot of consultation done late last year within the regions and with other jurisdictions that have existing registers. So there is work being done, and the sector will be updated on that as it progresses. Great. So I know that there were a couple of extra questions for the panel. So I'll just open it up to the floor for any questions. I think we're almost at 12:30, but we should have time for a couple more.
Lewis, I was just hoping you could just talk about the IgM and why that often is not positive even in an acute infection, just to clarify that.
Yeah, I think I wouldn't get too excited about IgM. The only real place for IgM is in congenital syphilis, because if the baby has a positive IgM, it means that they actually have syphilis themselves, because IgM is too big a molecule to cross the placenta. Otherwise, the baby serology just mirrors the mother's serology, and you have no idea whether the baby is actually infected, whereas the IgM will tell us that. In other people, it's the sensitivity of the IgM is not very good, and so people can have acute syphilis, and we know they've got acute syphilis, and we can see they've got lesions, and their IgM will be negative. So we don't get very excited about the IgM generally. It doesn't necessarily help us. It can do sometimes, but in the end, we're really looking at what the RPR is doing if we're looking for reinfection rather than relying on the IgM. And the IgM tends to fall within about 6 months, roughly. So the lab, PathWest will automatically do an IgM if it's thought to be a new case. But in the end, usually if it's positive, it's helpful. If it's negative, it doesn't eliminate acute syphilis. So it's one of those tests where good if it's positive, not sure what to do with it if it's negative. And then the other issue, I think, was serofastness, so-called serofastness. So those of you in the Kimberley will be well aware of this phenomenon where people are treated, they have an appropriate fall in their RPR after treatment, but they continue to have RPRs 1 in 4, 1 in 8, 1 in 16, ad infinitum. And these are difficult patients to think about. We always have to be careful to make sure that we're not missing reinfection. Is there low ongoing reinfection in that relationship, and their partners haven't been tested and treated? So again, why contact tracing is so important. But if you remember that the RPR is not specific for syphilis, it actually looks at anti-cardiolipin antibodies. So there are other reasons, immunological reasons why it might be positive, but also if people are being continually reinfected with other things, like parasites or worms or whatever, that can make their RPR positive as well. And injecting drug users will often have a persistently positive RPR just because all the rubbish they're shooting up when they're shooting up with the drugs. So, this is a well-known phenomenon, the so-called serofastness of RPR. You don't get RPRs of 1 in 64 though, but 1 in 16 is usually the cutoff. So you need to be very clear that, first of all, they've had an appropriate fall in their RPR. If their RPR has always been 1 in 16 and had no fall, then that person needs to be more investigated. But if it's come down and it stays at a lower level, 8, 16, continuously, and then that may be that they've actually got serofast level and there's nothing more that needs to be done for that patient. If they get reinfected, the RPR would go higher again. It would go up to 1 in 64, 1 in 128, whatever.
Thanks, Lewis. Has anyone got a final question for either Lewis or for Jean-Marie?
I have one more, just about this clumping thing and how how objective it is. That makes me nervous because we have had situations where we have 1 in 32 coming from one lab and then we go to another lab or we check it again and then it comes back as 1 in 16. That makes me kind of nervous. It doesn't sound that, it sounds a bit too objective.
Well, subjective, I think, is a problem, yeah. So I think that,
subjective, thank you.
Yeah. I mean, the inter and intra-observer error is enormous, but that's why we always ask for a twofold change to be significant, because the chances of someone misinterpreting a twofold difference is very small, whereas one-fold difference is not. And so if you do get an unexpected rise, from say 1 in 16 to 1 in 32, it's always worth asking the lab to test those samples in parallel, because then they'll get the old specimen out, and they do keep old positive specimens for quite some time. They'll get the old specimen out and they'll run them concurrently, and then you observe the clumping at the same time. So that's why they might go, when we ran them in parallel, they are both actually 1 in 16, because then they're looking at them both at the same time and you're not sort of comparing them across a time frame. So it's always worth asking the lab to test in parallel if you've got any doubts.
Thank you.
I'm sorry, this is Beth here from Carnarvon. I just have a question. If we had a situation where we tested somebody, they came back with a positive syphilis, I can't remember how much the RPR was, but they're negative, they had a negative syphilis test only in the 2 months previous, so we knew it was an acute infection. The partner was tested at the same time as the positive cases, and he's tested, say, negative. My assumption is that, we get him in to get him treated, but just in terms of how it develops, what would be your advice around that?
Well, he may not have it. She may well have presumably has had sex with someone else. That's where she's got infected from. So the risk for infectivity with syphilis is about 30%. It's not like 100%. So, but there's also a so-called window period for the blood test. So you'd be looking at about 6 weeks. So someone in that case where he was negative, she was positive, he was negative, then you'd repeat his test in 6 weeks. Might be earlier depending on what you find, but the maximum would be 6 weeks then to see whether his serology's changed. But just because she's positive doesn't mean he's automatically going to be positive. And as I say, chances are, therefore, she's had sex with someone else that you haven't found out about. Does that make sense? No?
Yeah, no, it does make sense. I think there was this assumption that we needed to get him and offer him treatment, but obviously it's more important to get him in and get him screened again.
Yeah, having said that, we do, in areas of high endemicity, because if sometimes it's your only chance to treat someone, you might offer them treatment. If they're a known contact of a known infectious case, you might offer them treatment on the day you see them. But if that's declined and you do the serology and it's negative, then you shouldn't just say, oh, they haven't got it. You do need to make sure that you get them back and retest them, because they could be incubating syphilis. So that's, as long as you know you're going to be able to get them back and retest them, you could do that. But if you've got any doubt, you might offer them treatment on the day you see them.
And if they were just incubating, would the treatment that you give them on that, like if, say, it had only been, say, 2 weeks since, we did the test, like if we give him treatment now, that's going to be effective against it, if he's incubating.
It will be. It will be, but also to remember that if you treat people very, very early, their serology sometimes never becomes positive. So so that's just another, you will never know whether they had it or not because you've already treated them, but sometimes that can happen. So if you do treat people very early in their disease, the serology may never become positive, just to let you know that.
Thank you. Thanks, Lois. Thanks, Beth, for that question. We're a little bit over time, but I just wanted to say thank you very much to Lewis and to Dan-Marie and to everyone who submitted questions. Hopefully everyone got the answers they were chasing, and it is a very complex situation, so I think it's good to get some clarity. And I just wanted to say, if anyone has any ideas for presentations or sort of topics moving forward for other VCs, please feel free to send them through. We really want to make sure we tailor these sessions to the needs of the sector and the workforce, so please let me know. I think we will probably end it there. As usual, this session was recorded and will be posted on the WA Syphilis Outbreak Response website. And thank you very much.
Thanks, Rudy.
Thanks, Lewis. Thanks, Jen. Thanks, Rudy.
See you, Lewis.
Bye, everyone.
Thanks, Lewis. Thanks, Rudy.